Just give me patience, yeah.
What up, Z-Pack? It's your boy Z-Dog MD, and I am here today. I'm so excited, Tom. Tom, are you excited?
I'm so excited.
Tom is so, look at his suit, people.
It's Palm Sunday, people, which means it's a pastel suit Sunday for me.
You look like a golf sportscaster from the 70s, dude. Like, it's amazing to me what you're doing right now with that. He's rocking this.
The
dude.
thing
he
is,
is,
Z, I'm going to put a little Dilaudid in my own body from about 20-yard distance. And back to you, Z.
Welcome aboard, Z-Pack. Guys, we are excited because today we're doing something incredibly special. We have a co-host by the name of Dr. Kathy Travnicek.
Hi.
Dr. Kathy! It's Z-Dog and Kathy T! Can you believe it? And we're going to be talking about opioids, chronic pain, PM&R, Dilaudid, all kinds of amazing things. And you know what, Kathy?
What?
They are going to be able to get CME and continuing education credits if you are a nurse, a doctor, or a PA. The rest of y'all can shut up, okay? Because we have to pay to get accredited for y'all, so just wait. It's going to happen eventually. But so stick with us. Watch the show. Ask your comments. We're going to answer them. And then you click through the front matter that you have to read because it's a legal thing, because this is medicine and we're highly regulated because we suck. Click the link, follow through, answer the questions, and you can get 1 unit of Category 1 credit. Boom! Just for having fun on a Sunday. What do you think?
I think it's great.
It's the bomb. Yeah. Kathy and I have never met until today. Kathy is a physical med and rehab doc who subspecialized in pain medicine. Is that correct?
That is correct.
Johns Hopkins trained other places too, yeah?
Cleveland Clinic is where I did my pain fellowship.
Here's where the name dropping starts. Tom, I told you don't let her drop names because it makes me look bad.
Dude, you always look bad. By the way, Julie Homer said this show's not live today. I just called you out on camera, girl. It's live.
Oh yeah, who's not live now, Julie Homer? So, because we've talked about opioids so often, and it's such an important problem, especially in America today with the opioid crisis and people dying and chronic pain patients wondering how the hell do we get care when it seems like doctors are now abandoning us as the pendulum shifts.
Right.
And the Surgeon General is putting out a letter saying, let's think twice about prescribing opioids and let's be careful and so on and so forth. People said, how about you get someone who knows what they're talking about instead of a dimwit hospitalist like me, and let's have a good conversation. And so we found Kathy.
Hello.
Kathy's in practice in Las Vegas, and she hit me up a while back, and she's like, I love your videos, I'd love to be in a video. And I'm like, no, you can't be in a video. And then I'm like, would you be on my show and co-host because I'm so lame at pain? And she came. And so tell us a little bit, what's your, let me ask you this question. You were a physical med rehab doc, but then you said, I want to be the doc that no one wants to be. I want to be the doc that sees the people with the chronic pain and the drug dependency and high opioid use, et cetera. How did all this happen?
Well, when I was in residency, I wasn't sure exactly what I wanted to do for a fellowship. I just wanted to practice and figured I would figure it out in practice. So I started my first job in Green Bay, Wisconsin.
Oh yeah,
And
Packers!
Go Pack Go! And when I was there was a physician who left, and I inherited a practice as opposed to building a practice. And I had it was basically a high-dose opiate practice. Back in those days, we didn't have, and it wasn't that long ago, we did not have prescription monitoring
She's like
programs.
23 years old, guys. It was like, yes, she's like Doogie Howser.
Like yesterday.
Exactly.
We didn't have prescription monitoring programs, and so I had a lot of different types of patients in the practice, some that were abusing, some that were addicted, some that had uncontrolled pain. I had diversion, I had doctor shopping, I had really everything. And so through that experience and really working to clean up the practice over about 1.5 years, 2 years, and seeing the positive changes that I made, I wanted to do pain management, and that's how I decided this is what I want to do.
Wow. And you know the reason I picked her for the show, we literally spoke 3 days ago for the first time on the phone,
Yes.
and I asked her one question. I said, what do you think of Dr. Oz?
Douchebag.
You're hired.
Thank
Done.
you. Thank
Done.
you.
So
We love you, Kathy.
your sister's a registered dietitian, right?
My sister's a registered dietitian, and she said Dr. Oz is one of the worst things that has ever happened to nutrition, dietitian, the world of diet.
Oh, you mean green coffee bean extract doesn't save your marriage?
Maybe, I don't know.
Well,
Yeah.
you know, you never know.
Yeah.
So having you on the show has been a great gift because number one, you can help me not look like a total idiot about opioids. Because even though I manage chronic pain and acute pain as a hospitalist, I often fall into the same patterns of practice that many doctors do. And also, there are so many members of the Z-Pack, 1,000 of which are watching right now live, that oh, how dare you, Nikki McIntosh. Z, I'm not digging the suits. It's Suit Sunday, Nikki.
It's Suit Sunday, Nikki.
What don't you know about Suit Sunday?
It's Suit Sunday.
I did ask to wear pajamas.
She did. And I was like, no pajamas for you. If we're wearing suits, you got to dress up. And she was like, I'm out. And I'm like, okay, wear whatever you want. She was kind enough to. So there are a lot of Z-Packers who have chronic pain, who are worried about, and they're on opioids and they're worried. And I tell you, a lot of them message me privately and say, I realize I'm addicted. I don't know what to do. And so I want to pick your brain and see what we can how we can educate people on chronic pain, opioid use, opioid dependency, opioid hyperalgia, all these different things that keep coming up in conversations. And if we don't get it all out today, if y'all like Kathy, tell us in the comments and we will bring her back to co-host because it's got to be Z-Dog and Kathy T. You know what I'm saying? So what do you think? When you started this practice, you picked up this practice full of people on high-dose opioids. How did you manage this?
Well, since I was just out of residency and I hadn't done a pain management fellowship, I was first in shock and disbelief and realized I needed help. So I had help from my partners, and then I also reached out in the community to a very dear friend of mine who was at another, I met him through different meetings, dinners and whatnot, and he was doing pain management. So I really kind of got a team of people together who had been doing it for a while and did a lot of reading and used my personal training background, kind of putting everything together.
You were a personal trainer before this?
Yes.
Oh,
Yes.
okay.
Yes.
That's interesting. So you did a lot of coaching and stuff.
Lots of coaching. Lots of coaching and teaching and mentoring and trying to help these patients really change their lives. It's really, a lot of it's about behavior change and education.
No, I'm sorry. Wait a minute. Are you saying that the patient has some responsibility for changing their behavior?
Yes.
Oh dear.
Yes,
Get
you
ready
do.
for the hate. Watch the comments, guys.
Here we go.
Watch them come. I agree with you 100%. Please. So you had this personal training background. You were PM&R, but you didn't have the pain background.
Right.
And you had this panel.
Right.
Yeah.
And so I sat down and said, okay, what do I need to do to clean this up? And I you know, thinking of all the things we had in practice then, I didn't have the prescription monitoring program. So what I had to do is I had to get more family members involved. I asked people to bring in family members for outside reports. I redid the pain agreement. So a pain agreement, whenever you're in a practice, you get opiates from a physician, you have to sign something saying, I will use these appropriately, I will not sell these, I will not give them to my friends.
And this is like a guideline, right? Because you know that people don't really, like, look at Tom. I'm sure he has like 15 pain agreements, but look at him. All right. So you do the pain agreements.
So redid it. So when the patient came in, and I reassessed, everybody got a reassessment. I would go through their chart. I would go through all their medications, what they had tried, what they failed. I basically kind of started from square one.
Yeah.
And so there were some patients that had that didn't need to be on opiates, that were made worse by the opiates. There were some people that were getting good pain control with the opiates. There were some people that were on the opiates, but they weren't getting pain control. They didn't have more pain, but they just weren't doing well. And so it was trying to figure out, and it took time to figure out who could stay on, who could come off. And so I had a mixture of different patients, and it took a while to kind of figure out where people were going to end up.
Wow. I mean, if you were to kind of subdivide those batches, how do you think was any in the majority? Like, did you find that the most of your patients didn't need to be on opioids, or was it kind of spread out throughout?
I would say it was a mix because it was such a mixed practice.
Yeah.
If I could go back and look at where all those patients were at now, that would be awesome. Because then I could know who went into addiction treatment, who was with another pain practice that is doing well because they just didn't like that I was coming in and changing things.
Right.
I did get people off opiates completely and exercising, so there are some really good success stories that I had, which also was what motivated me to do pain management. And some people came off, some people did not. But I was able to reduce opiates in most people.
Were you obligated to report diversion and things like that?
That's a good question. So at the time,
By the way, diversion, for those who don't know, is when you're taking the drugs that are legally written for you and you're diverting them somewhere else, you're selling them or you're giving them to other people.
yes.
Dr. Kathy, would you like a water?
Yeah.
I'm gonna
I
get
would.
you one. I'll be right back.
I did see a comment.
Wait, is
Give
this-
me some water.
Is this,
Yeah.
Do
is
I
this
look
yours from earlier?
dehydrated?
Is this yours from
Yes.
That one is hers.
This
Yes.
is yours. Here you go.
Yes.
We like to keep people very dry on the show because having to put in a Foley mid-episode makes it very awkward.
The Z-Pack was yelling at me. They were like, Tom, good God, hydrate your guest.
We have no idea how to have guests, people. First of all, who called her a guest? She is not a guest.
Co-host, people.
She is a co-host. It's Z-Dog and Kathy T today, people.
Oh,
So while you
I do have allergies. I see the clearing throat. I'm sorry.
Oh, I do it too.
I have some allergies here in Vegas. They're new, so.
So our next
sorry.
co-host is going to be an allergist and a GI doc who's going to scope us both in real time and see nothing but Barrett's esophagus
Great.
all the way up. I do it too all the time. Do you find certain foods make it worse for you?
It just started 2 weeks ago, so
That's Vegas.
Yeah.
It's Vegas in the
Yeah.
spring.
Sorry, I will stop doing
No,
that.
no, no.
Danny says, forget the water, give her some wine.
Oh, I like that.
Do you drink
yeah,
wine?
I do.
Okay, I found my co-host, people. Hates Dr. Oz, check. Drinks wine, check. Has GERD, triple check. So you kind of, the diversion piece, having to report it.
So I remember I had 2 people that I suspected it, and I had asked different physicians their opinion on whether I should report it and who to report it to, and I got different opinions. No, that's not your responsibility. Yes, you should. That is your responsibility. So because both of them, I was basically the main supply, and after I found that out and I stopped it, I ended up not reporting it.
I see.
And going back, maybe I would change that, but at the time, I had gotten many opinions not to do that. That was not my job.
Not your role. Do you ever feel like a drug dealer in those situations?
Ooh. When I found out about that, I did.
Yeah.
But when I cutting it off, and then I did not feel that way anymore.
So you had you had a choice there. You were like, I could break bad and get that guy's number, and we could party and get rich,
basically.
or I could do the right thing, obey my Hippocratic oath, and be awesome. And
I
you
decided the latter.
chose. Ah, you're so boring.
I know.
I don't know if you can be a co-host on this show.
I know.
I know, but I'll let
Sorry,
you anyways
guys.
because you're awesome. So in the setting of that, now the question was, what sort of prompted you to say, I need more training to manage pain because it's more complex than I thought?
The entire year, I mean, I wanted to do more for patients. I really I could counsel people in exercising. I could send them to get addiction treatment. I had to send them out for various injections. But I didn't feel that I was really the specialist that I wanted to be.
This
And
was
so
as a PM&R doc.
Yes.
Right.
And so I wanted to do everything in pain. I wanted to be able to, if they needed an injection, to do that, or if I needed to, and I didn't know how to deal with headaches. So there were certain pain conditions I was not good at that I did not know, and I wanted to be able to do that.
Got it. So then you went back, did your fellowship at Johns Hopkins?
Cleveland Clinic.
Cleveland
was the
Clinic,
fellowship.
right, got it. And then Johns Hopkins, what was that?
That was my physical medicine and rehab residency.
Got it. Okay,
Yeah.
I get them all backwards because she's just too accomplished, and then I get. So once you had your training in pain, you were able to do certain procedures. You were able to manage acute and chronic pain in a different way. What changed in your mindset after that training?
So when I inherited the practice, I was tapering opiates.
Yeah.
And so everybody was coming off. I didn't know how to, if somebody came in and they wanted to start them, I was afraid to do that because of what I experienced. So I didn't really know how to start them, who to start them in. I just knew how to taper.
Oh, wait, it's easy.
Yeah.
Just give them like 120 Vicodin, and then you just escalate it, and then their dentist gives them some.
Yeah.
That's how it works, right?
Yeah, exactly.
Yeah.
Yeah, basically. In some practices, it's how it worked.
Exactly.
But I also wanted to be able to do other things for patients, so that's why I ended up going back.
Mm-hmm. And did you find that then when you went back to your practice, how were you looking at me? Because now we're thinking there's so much chronic pain, acute pain. Primary care docs are really a lot of times in the dark.
Yes.
And we end up doing the wrong thing. We use the wrong agent for the wrong pain for the wrong duration, and we end up creating part of the problem. And I think in many ways, I feel like as a hospitalist, I was part of the problem. I would send people out with these long prescriptions if they were post-op or whatever it was, and then dependency happens pretty quickly. And then they would go. Then I would send them to you, and I'd throw my arms in the air and go, I don't know what to do with this person. They're driving me crazy. Are they a drug seeker? I don't even know. Just go here and sign a pain contract.
Yes.
And were you seeing a lot of that? Like how did you manage chronic pain?
I did see some of that. There were two things that I saw in terms of other specialties. One, besides primary care starting it too soon, was also when patients go in for surgery, various surgeries. I remember my own experience. I went in and had a pinning on my finger.
Ooh.
And before the surgery, the nurse came in and said, "What would you like for pain?" And I said, "Oh, I have a choice.
I have like
What
a
are my
side
options?"
of 3 of Dilaudid and a couple of, By the way,
Would you like to supersize that, sir?
I'd like to supersize the Percocet with a side of number 3
And
codeine.
would you like a small snack size McFlurry as well?
I'd actually like several deconstipating agents as well as, God help me, right? So,
Yeah, so I was pretty shocked, and so I said, "Well, what are my options?" And she said, "Well, we have hydrocodone or Percocet." I said, "Well, okay. I don't really know what I want." So I said, I can't remember which one I picked. I just picked one randomly. And so she gave me a prescription for 5 milligram, 325 milligram, and I think I got 30 pills. I used 2. I didn't have that much pain. So we have opiates also coming on the surgical specialty side, where I didn't get any education opiates. Nobody asked me if I had addiction, an active addiction. Nobody asked me if I had a family history of addiction. Nobody educated me in opiates. I got nothing, but I got handed a script for 30 tablets.
So let me play devil's advocate here. I'm the doc or the nurse or whatever, or nurse practitioner, whoever's doing that, and I've got 10 minutes to see patients. I've got 30 charts in Epic to click boxes through. I'm paid based on patient satisfaction, so if I don't give you that, if I have a long, hard discussion with you, I'm screwed. How do we handle this? I mean, as primary care physicians or frontline providers or surgeons or whatever it is.
I think it's a tricky question.
Yeah.
I mean, it's not easy. In the environment we're in, it's so difficult because we have to spend more time with our patients, and a lot of us don't have that time. And so I do know some physicians, at least some primary cares, that just will not do opiate management.
They just won't do it.
Because they cannot handle it in their practice.
So let me ask you a question. You mentioned time in Health 3.0, the whole idea, this idea that we're beyond this commodification and we're not paternalistic, we're partners with our patients.
Right.
So that means we hold them accountable, they hold us accountable, but that means we have to have the time to be their shepherd.
Right, absolutely.
As a pain doc now, with all your training and your special background in being a personal trainer, being PM&R, how do you spend time with them? Like someone comes in with some pain issue, and you can talk about any aspect of that you like. You know, it's chronic pain, is it neuropathic, nociceptive, mixed pain, whatever it is. How do you integrate all this with the time you spend and figure out how to hold them accountable and make them a partner?
Yeah, so it usually happens over a few visits. Sometimes it doesn't happen in the first. Sometimes in the first visit I do have enough time. I have the records before, I review the records. I kind of have an idea of what's going on. I go through what they've failed and what they've tried. And I always try to pretty much try everything before I would do an opiate. I mean, opiates are for moderate severe pain in someone who's failed a lot of other things.
Oh, you mean they're just not something you get for your wisdom teeth and get 1,000 of them?
Right.
No.
Right.
My dentist.
Yeah, but and then in the follow-up visits, I'd really focus on, I have the history, I have the diagnosis, but I really want to focus on the social history. What are they doing for exercise? What are they doing for diet? What are they doing in their free time? Do they have any other addictions? What are they doing on their part?
Do they have any other addictions? What do you mean by that?
So there are, I mean, the most abused substances in the country are nicotine and alcohol.
Suck it, big tobacco and big alcohol, okay?
Yeah.
Legalize weed. Am I right? Give it up.
Boom.
She's like, not at all. So please, so nicotine and alcohol, and how does that affect how you think about this patient?
Because they have a history of addiction. And so if somebody has a history of addiction, they're at higher risk for being addicted to opiates. And you can be addicted to food. I mean, there are these food companies.
Guilty.
Food companies have scientists that will go into a lab and they try to find the bliss point. If you haven't heard of the bliss point,
tell me more.
So the bliss point is they make the processed food has the perfect amount of sugar, salt, and fat, and it is the most tasteful, wonderful thing you'll put in your mouth. And then they process that and they put it in a box and they sell it to you. And people can be addicted to these substances because it hits that reward center in the brain.
I just dopamined all over myself.
Yeah, basically.
Heineber.
Yeah, hit me.
Cheetos, stat. Now.
You ever heard of a McFlurry Z?
McFlurry?
It's the best thing on earth.
In chemistry, they call it the triple point, where things are simultaneously a gas, a liquid, and a solid. That's the McFlurry, people. That is the McFlurry. So this history of addiction, and you bring it up with food addiction, this idea that scientists can actually game the system to appeal to our addictive capacity, everything from McDonald's to Cheetos to processed food, which again gets to the whole point when we talk about Health 3.0. We should just be eating real food that isn't processed, that comes from actual sources that we can name, that aren't a machine.
One ingredient, I tell people one ingredient.
And if that ingredient is carrageenan, so be it, okay? If that ingredient is guar gum, then let it rain, okay? So you kind of make this evaluation, like, do they have other addictions? And then how do you proceed? So let's say Tom, who has an acute back injury that now has become chronic, where he's had it for 3 years. He gets steroid injections occasionally. Sometimes he gets low-dose narcotics. Sometimes he gets ibuprofen.
I wish they would give me narcotics. I don't consider tramadol a narcotic.
Do you disagree with that, Kathy T?
I don't really disagree. I mean, it has some mild opiate properties, but it's not really a main concern when it comes to addiction, at least from my perspective. And there may be people that disagree with that.
But it sounds to me like your practice, though, is more people who are on high-dose narcotics maybe, or already have a problem.
That's what it was, yeah. My first practice was like that. And so I always, when you're evaluating a patient, they come in and they bring all this stuff to you, you have to make your plan based on their baseline. So where is the patient starting, and where do you want them to go, and how are you going to get there? So for example, if someone came in and they were not exercising at all, they had never exercised in their life, and I really wanted them to do that.
Logan?
Nothing.
Nothing? Please continue. Not exercising.
And I really wanted them to do that. I had to figure out how I was going to do that. So you have to sit down with patients. Why are you not exercising? What are your beliefs about exercising? Have you ever done it before? And if you have, when was the last time you done it? What are the barriers to exercising? So when you're trying to make goals for patients, this is with medications, this is really, and with diet, with anything, you have to take a step back and figure out where the patient's starting from, so you kind of know where to go.
And that involves time and talking.
Yes, you actually have to talk to your patients.
Can I ask a crazy question? Do you get paid to do that?
Not really.
Not really.
This goes into a good question from Danielle Marie, who says, Kathy, so you're weaning people from their opioids, telling them to exercise, advising them to eat one-ingredient foods. How do you stay in business?
How do you stay in business when you're asking them, giving them tough love?
Right. I give tough love, but I don't fire them if they don't do it. And I'm not having them do it all at the same time. It's a stepwise approach. So if we have one goal, so most people, if you give them a lot of things, they're not going to change everything at once. I mean, one thing at a time. So I had one example. I had a morbidly obese guy come to me. He was on Percocet for low back pain. He was not exercising. He was drinking 3 liters of Coke a day.
Wow.
So I said, we're going to do one thing at a time. So that each month he came in, each month was a different goal, and I made it very specific. So SMART goals, if you never heard of SMART goals, we'll go over that, but it had to be very specific, measurable. We could measure exactly what he had to do. It had to be attainable, reasonable, and he had a time point. So he had to cut out 1 liter of Coke a month.
Yeah.
So that was all he had to do.
Wow.
And so when you make small goals and people think, I can do this, if they're motivated enough and they want to do it, they will do it. So he came back a month later and he had actually cut out 2 liters of Coke.
Wow.
A month after that, it was 1 liter of Coke. And then, so we had no Coke at all.
That's a lot of cocaine.
It's
Oh, sorry. We're talking
Whoa, sorry. Not cocaine, Coca-Cola, the soda.
I hear what I want to hear.
Jeez, addicted to sugar. He was addicted to sugar.
Which is a horrible addiction.
Yes, absolutely.
And it's a national epidemic we barely talk about.
Kathy, how do you make people see that, though? I had a friend who was telling me that he should really be exercising 3 times a week. And I said, why don't you just exercise 1 time a week? And he was like, what's that going to do?
Right. And so I think people want to get to a place, they don't know how to get there. Yeah. And so you have to, again, it's the same thing with realistic goals. Okay, you want to be exercising 3 times a week or 5 times a week at an hour at a time, but you can't start there. you have to start at a much lower intensity, less time, and spread it out, and then gradually increase every week. And even athletes do that when they're training for competition. They don't just go and compete, or they don't just go and make records. They actually they have a special training schedule, and it is changed week to week, and it increases each week a little bit based on what they did the week before, because you have to make slow gains in order to get better.
Right, because when I started pimping, I didn't just jump into the game.
That's right, it takes time.
It took several, I had to slowly, like she better have 70% of my money. I didn't need 100% right away.
Right.
Plus, you got to get one of those hand squeezers to keep the pimp hand strong.
The pimp hand, it's hypertrophied now, but it wasn't always that way. It takes work, people. I have a question here from Angie Margolin, and this is a little bit of a sidetrack, but I think it's important. I want to ask you it.
Yeah.
What are your Angie Margolin says, what are your thoughts on medical marijuana? I have had 5 back surgeries and have rods in my back and a fused neck, and my doctor tells me to get my medical card to help me deal with my chronic pain, but I don't like weed.
Oh. I don't know that much about medical marijuana. The DEA does not allow us to prescribe it. So my prescription legally, marijuana is Schedule 1, and so I'm not allowed to even prescribe it. We don't know enough about marijuana. I do have patients that do come in and say that they use the topical oil or the topical the
CBD oils
the
and things like
CBD
that,
oils, and they do feel benefit, and some people don't feel benefit. I don't think we know enough for that. Yeah.
You know what might be interesting, because I know a lot of people are passionate about this subject. You and I co-host one time, and we get an expert on in medical marijuana.
Oh, we should do that.
Yeah, because
that would be good.
I think there's an anxiolysis issue, like where you help with anxiety. And how much of pain do you think is really, as we say in the business, supratentorial, in the head? In other words, it's in the experience and the perception of it. Is it all of it?
It's tough. I mean, no brain, no pain, right?
Right.
So if you
That's why Tom feels nothing.
No.
Yeah. He's just, look at him.
I don't even need opiates because nothing's going on up here, y'all.
You guys remember the decerebrate cat from medical or nursing school?
Oh my gosh.
No brain. It just walks on a treadmill like this.
Basically.
Yeah, must eat, poop, and pee.
Kathy, what are your thoughts on kratom? Do you know anything about kratom?
No, what is that?
No, not at all.
Yeah.
It's like a plant-like substance that they sell at gas stations that a lot of people are using as a Suboxone type, replacement therapy.
Tom, Kathy's
That's
a real
first for
doctor,
me.
not like me.
People are asking in the comments, okay?
Yeah.
Yeah. No. So kratom is
Sorry,
another.
I don't work at a gas station. I don't know.
Maybe you should.
Maybe I should.
You know what? Maybe I need a different co-host.
I do
who
need to
works
work
at a
on the
gas
weekends
station.
more.
That was great.
You know what they have down the road, by the way, Kathy? They have a Shell station that still has full serve, and they have all these high school students pumping gas, and so you'll pull up and roll down the window, and they'll be like, "Hi, can I help you get your gas?" And you're like, "Get out of my face!"
Too many Monster drinks.
Exactly. I pump my own damn gas, okay, and I don't have money to tip you.
It's like, listen, bro, you got back pain, you're going to want to get a bag of Funyuns. The kratom's over there next to the Slim Jims, okay? Snap into a Slim Jim!
Oh, we've broken our host already. We've broken our host. It hasn't taken long. There was other things for sure I wanted to make sure that we hit, and one of them is that patient responsibility, this idea that they have to put in the work.
Yeah, and so when I sit down with a patient...
By the way, Kathy does see patients. I've seen a few comments asking, does she see patients actively?
Yes.
She's in practice here in Las Vegas.
Yes. This is a team. I don't tell you to do things and then you just go do them and you do whatever I say and that's it. And also, I can't do everything for you. And so it's a team. So I'm 50% of the team and you're 50% of the team. And so my responsibilities are to reduce your pain and get you functioning. And your responsibility is to really exercise and take care of yourself and live a healthy lifestyle. At least we have goals towards that, and I make different goals based on the patient, as well as abide by the pain agreement, or pain contract, or opiate informed consent, whatever you want to call it.
Opioid-induced hypersensitivity.
Yes.
We hear this bantered around a lot, and it's a lot of reason why primary docs will be like, well, he just has opioid-induced hypersensitivity. Explain what it is and why it matters to your management of patients.
So we don't know how common it is. When a patient comes in and they're on high-dose opiates or any type of opiate and they have a lot of pain, there are a few questions you have to ask. That's not always the diagnosis right away. So it can be untreated pain. It can be opiate-induced hyperalgesia. It can be that the opiates are just not working.
Can you describe what opioid-induced hyperalgia is? Because I'm an idiot and I don't even know.
So
I use it a lot. I'm like, yeah, it's just that.
We don't know why it happens, but we do know that people are on opiates and the brain isn't reading the opiates, and so they have more pain. It may be the same pain or it may be a different pain. They also they'll be very hypersensitive, so they have painful responses to things that are usually not painful, which is called allodynia. And we think that it's due to changes in the nervous system, so changes in the central nervous system, peripheral nervous system.
Like upregulation of nervous sensitivity.
Yes, yes. And so, but it's hard, you don't really know that you're dealing with it until you taper them off opiates, and then they say, hey, you know what, I feel a whole lot better.
Okay, here's a question. Someone comes in, you may suspect them of having opioid-induced hyperalgia or just being on a ridiculously high dose of opiates and not getting effect. And the idea is, well, okay, first of all, how do I control their pain? How do I get them off the opioids? How do you talk to them about this? Because I know people get terrified when you talk about even taking their opioids away.
Absolutely. And when I first started, the most common thing that patients said to me were that you don't know me, you don't know my pain.
That's what I tell my mom.
And oh no.
I know.
You don't know me, you don't know my pain. You don't have chronic pain. So those were very difficult things to overcome. So I did it by educating. Yes, I don't have pain, and no, I don't have your pain. But here are the options we have of what could be going on here. Wouldn't it be great if we could get you off this medication and maybe reduce some of the other medications you're on because you're taking those for the adverse side effects you're getting from the opiates? And you will actually feel better, less medication, and think better, and be able to go to the bathroom.
Pooping is a thing.
It is a thing.
So how do you deal with opioid-induced constipation? Do you watch Super Bowl ads for Relistor or whatever and just, hope that things get better?
We did a lot of constipation management in residency because we have spinal cord injury and brain injury, so they don't have normal
PM&R
functioning.
residency.
Yes, exactly. So I usually have them start with over-the-counter stuff, fiber, that kind of thing, and then kind of go from there. I don't always prescribe the newer medications that are out. I think I've only prescribed it twice, to be honest. Yeah, a lot of people, at least in my first practice, when they came in, they were self-managing it. And if they weren't, a lot of people, they won't tell you, hey, I'm going to the bathroom every 5 days, because over time it becomes so normal to them that they don't think they're constipated.
Right.
So you have to ask about it. So I would ask, okay, what are you doing? And then what treatments they tried in the past, and then figure out from there what we were going to do next.
So it's the one side effect of opioids that never really gets better or goes away.
Correct.
Right? Yeah. And what are some other side effects of opiates that maybe people don't understand that well and that we can start to recognize in our patients who are using high-dose opioids?
So
or any opioids?
The ones that I think that family members are the ones that pick up on the most are changes in personality.
Oh, wait,
depression.
Sorry. I'm sorry. Are you saying people on opioids have changes in freaking personality? What are you talking about? You don't know me, you don't know my pain, and I'm really scared of you right now because look how she's staring me down. She's good at this. Like, I got in her face. For people on the podcast, they can't see this. I got in her face. She didn't flinch. She looked at me like she ran the show, and I got scared. That was amazing. Oh my gosh. Anyways, I'm sorry. I interrupted you because I'm that guy.
What was the question?
The question was how, I don't remember what the question was. What were we talking about, Tom?
Look at the comments.
We were talking about what are the other side effects based on personality, like
Oh yeah, you
personality
were
is a
saying
major side
that's right.
effect.
Personality derangements are what family notice in opioid using patients.
They have some memory issues. They're tired. They're more sedated. They're sleeping more. Just more blunted affect. And these changes happen with time, and they happen slowly. So some patients don't realize that they've happened until they've come off opiates. And when the patients that I had that came off opiates, they would come back and they would all say the same thing: I can think more clearly. My mood is better, and I can go to the bathroom. And I have the same pain, or it's better, or it's less pain.
Wow, that's a good day for me.
And
when all three of those things are true.
Right, exactly.
Yeah,
when I go to the bathroom, I feel
oh
great.
Oh my gosh. Right, Tom? Am I right? Are you feeling me?
Dude.
Yeah.
Kathy, what do you think about MCT oil for opioid constipation? Do you know about MCT oil?
Medium chain triglyceride oil?
I don't
This
know.
sounds like one of these like.
Because Z's got me on this keto kick, and when I take this stuff, I poo my pants. It's terrible.
It's probably because you're malabsorbing it. So it's these medium chain triglycerides. If they're not absorbed, they create like a steatorrhea, like an osmotic sort of pull.
Do you wear a diaper?
Oh yeah.
No, totally not.
Yeah.
I just let it go.
Let's see here.
Let's talk about post-withdrawal syndrome after long-term opioid use. Priscilla Lehman wants to know.
Post-withdrawal syndrome.
I've
not heard this term.
I've not heard this term before. When you're on an opiate, the normal response that your body has is that you'll become tolerant and dependent. This is normal. And so when you try to stop it abruptly, you will have withdrawal symptoms, and that is not pleasant. You get sweaty, jittery, anxiety. You kind of unleash the animal, and so you're being depressed by the opiate, and then when you take it away, you have nausea, vomiting, diarrhea, all these symptoms. And so we can manage the withdrawal symptoms with 2 medications. One is called clonidine, and the other one you can use is baclofen. I use clonidine more often because I think it helps better.
Can people die from withdrawal?
Opiate withdrawal, no. You can die of an opiate overdose.
Can you die if like the adrenergic surges that come with opioid withdrawal, though? I mean, if you have a cardiac condition, et cetera.
I think you could.
Seen similar
I think it's
stuff like that.
possible, yeah.
But
Yeah.
not necessarily from the drug itself.
No, right.
Yeah. Unlike with benzos or alcohol, where the withdrawal itself can
Yes,
be fatal.
you could, absolutely.
How about this mix of benzos and narcotics? Are you seeing a lot of that as a problem?
I used to. So what I did in my first practice,
And by the way, for the muggles, the non-medical people, benzos are things like Xanax, Valium, these depressant drugs that a lot of people take for anxiety or for sleep
Yep.
or for abuse.
Yep. So in my first practice, I had a lot of medication with benzos and opiates, and I did not feel comfortable with that at all because there were a lot of overdose deaths with those 2 medications. So we had a psychiatrist. I called him and I said, I need your help. So we had any patient that was on both, I would say, we need to manage your anxiety better. These 2 medications together are dangerous, and I would send them to the psychiatrist who actually would change the medication.
Yeah.
So you have to get help, and you need other physicians. I don't manage addiction, so if I had a patient who had addiction or I suspected it, I would refer them to an addiction specialist or to addiction center. If I needed help with mental health disorders, I get a psychiatrist involved. There's so many things that are going on. Even as a pain management specialist, you can't do everything.
How do you recognize addiction? Because I'm sure you have to tease that out.
Yeah, it's tough, and it takes time to recognize it. I think the red flags that we see in practice, I wrote them all down so I would not forget a single one because I knew I would. So red flags are doctor shopping, and I had some of that in my first practice, and all those people ended up in addiction treatment.
Doctor shopping once again when I told you I got 3 slip discs, chronic migraine, RSD, and abdominal pain. I define secondary gain. Did I mention I got allergies to Toradol and Motrin? That kind of doctor shopping?
Yes.
Oh,
Actually, they're allergic to everything. You missed all the other medications.
Oh, sorry, morphine, aspirin,
gabapentin,
oxygen, Lyrica.
Water.
So why is that a red flag?
The gym.
The gym. I'm allergic to the gym.
I did have a patient tell me that she was allergic to the gym once. It was awesome. No, it's a true story. So I wanted her to exercise, as a side note, wanted her to exercise. She told me she was allergic to the gym. She couldn't go. And at one point, I said to her, I really can't help you. And this is to physicians and nurses and even patients. The physician-patient relationship, it doesn't always work. And sometimes you have to find another physician. And physicians know that you can't help everybody. If somebody doesn't want to be helped, know that you cannot help them.
We can't take that burden on ourselves.
Right, exactly.
It's going to burn you out.
Exactly.
So doctor shopping.
Doctor shopping, when they're calling on weekends or they're calling on when you're on vacation, they're calling when you're away to try to get another provider to write something.
How many Z-Packers have experienced this? Keep going.
Lost stolen medications repeatedly.
Dog ate my Dilaudid.
Dog ate the Dilaudid.
Dilaudid.
Dilaudid,
That's
yeah.
one I haven't heard.
So there was a patient who came into the office. Usually when the patients come in, sometimes they'll give you specific medications that work. This gabapentin really works for my sleep, or Xanaflex really works for my muscle spasms. This patient came in and said that the only thing that worked for his pain was Dilaudid. And anybody in pain management knows that that's Dilaudid.
Dilaudid. Wow, Dilaudid.
The Dilaudid.
I like the Dilaudid.
Dilaudid.
Hey, Tom, are you on the Dilaudid right now?
Dilaudid kind of sounds like Billy Bob.
Hey, Dilaudid.
Dilaudid.
Dilaudid, bring that, get that Dilaudid back in here, Dilaudid. So specific names, allergies.
Frequent visits. So if they come to the office without an appointment, that actually happened in my first practice. I didn't understand what that was due to, but they're searching for more medications. Frequent phone calls. If they're calling all the time, they're using up your nursing staff, your nursing time. They can be a drain on the practice. And then they self-increase multiple times. So they're coming up, they're 10 pills short, they're 20 pills short on repeated visits. And then nothing works but opiates. Nothing works but Dilaudid or Percocet. So when they're allergic to everything else in the world and the gym and only opiates work, red flag.
Can I ask a silly question? So related to this, what is this idea of central pain sensitization, distinguished from opioid-induced hyperalgia? So central sensitization, is that a thing? We talk about someone has a bad injury or a bad pain and it's allowed to go unchecked and it somehow upregulates pain sensitivity and it's harder to treat. Have you seen that in practice?
Yes, yes. So we see that. I think you're talking about complex regional pain syndrome, or you mean
different, more like this idea of the term that I see in the literature occasionally is central sensitization. So somewhere in the central nervous system, there's upregulation of pain sensitivity due to repeated painful stimulus.
Yes.
Is that something that you see in your practice, or is it more like an academic construct?
I mean, you do see people who have lots of pain, and we think that it's the nervous system is sensitized. What I tell patients is that your brain is on fire, and we have to try to calm it down. But in terms of why that happens or how it gets there, we don't really know that.
Tell me, how do you when you're trying to paint a picture, and remember, a lot of these guys are listening on podcast, they're going to listen afterwards. And remember, we can get CME and CE if you follow the front matter and click the link. If you're going to describe to a patient on the phone this idea of your brain being on fire and receptors and that kind of, how would you describe it to them if you're talking about opioids and pain and sensitivity?
So if I'm educating a patient and whenever I was educating patients on opiates, tolerance dependence, and what happens to their brain and what we need to do to bring the opiates down, I would draw pictures. Some people learn by talking, and some people need to see it, so I would do both. So I would draw a picture.
I learned through song. Do you ever sing?
I'm a horrible singer.
That's awesome, but someone here says, Amy Constantina says she's amazing, great co-host, keep them coming.
Oh, fun,
So
thank you.
sometimes you draw a picture, and sometimes
I draw a picture. Well, actually, I always draw a picture. Always draw a picture and talk, because people learn in different ways. They either have to see it or they have to hear it, so I do both. And you draw a brain, and I'll just draw 2 receptors. And then I have O at the bottom, and I write P for pain. So your acute pain is protective, right? So you touch fire, ouch, pull hand away, you
unless you're Tom, in which case you're like,
and you keep the hand there.
This is your
hand
brain
there.
on drugs.
Or let's say, a good example is, let's say, a fracture. So you fracture your leg. You go to the hospital, you get some opiates. The opiates go and they block your pain receptors so you don't feel pain. You do your rehab, you get better. You come off the opiates, you have your same brain with your same receptors. The brain will go back to where it was. So back to baseline, the same kind of concept. With chronic pain, it's different. So you have the opiate, and the opiate, doesn't matter what it is, fentanyl, morphine, hydrocodone, oxycodone, whatever. Fentanyl, if I didn't mention that. It will go to the brain, right? Blocks the receptors, so you don't see that pain. But over time, when your brain is continually stimulated by the opiate, it doesn't see the opiate anymore. It's just decreased response. So then your pain goes up. And so what I draw the picture, instead of, I can't draw the pain receptors becoming sensitive, so I just draw a few more. And so it's a protective response. The brain wants to feel pain because it's protective. So a few more receptors, and then your pain goes up, and then you go up on the opiate. A few more receptors, and then your pain goes up, and then you go up on the opiate. So it becomes this vicious cycle. We can reverse that, and your brain can go back to the way it was before, but we have to do it slowly. And so as I take a little bit of the opiate down, your pain goes up a little bit, but your brain sees that, and it takes back, kind of calms down. And then over time, we slowly get there. There are different tapering schedules. I do depending on the patient, I decide I don't have a hard line. You have to do this. It's all relative to the patient. But we can get back to baseline, and we can get your brain back to just having those same baseline receptors that are not hypersensitive as before.
That's a great way to actually conceptualize it, because sometimes that little bit of pain that you do have is an adaptive response, and it will overall help you in the long run. So a little bit of pain is a lot of gain when you're tapering opioids.
And when I was doing those very slow tapers, the patient, I just started. I hadn't even done this. I was believing my mentors. I was believing what I read. And
Never believe that.
Yeah, no, mentors.
Clowns.
I would say, I would tell them exactly what would happen. Your pain's going to go up a little bit, but you're going to be able to get through it, and then it's going to come back down. And they would come back in 3 weeks later, 2 weeks later, 4 weeks, depending on what we were doing, and they would say, that's exactly what happened. My pain went up a little bit, it wasn't that bad, and then it went back to where it was at now. And then they were ready to continue to taper. And that's that is a beautiful thing.
That is a beautiful thing. And you know what I think really sets the stage for that is that you set their expectations.
Yes.
Because otherwise, how many of us have tried to taper opioids and people come, I'm in pain, or they're calling you in the middle of the night.
You don't know my pain.
Yeah, you don't know my pain.
Yes.
You don't owe me pain. Will you return it? I'll say it again. Pain. Hit me, Logan. Sons! You think it's time to go to overtime? Hit some comments?
Real quick, Chris Papish says that Dilaudid is 4 to 5 times more powerful than morphine. And I asked Dr. Kathy about this before, and she told me...
So opiates have different potencies, yes, but we can do conversion factors, and you can make one opiate the same potency as another depending on the dose. So the dose will be different, but yes, Dilaudid tends to be more powerful than morphine, but if I give you a lot of morphine, it can be the same thing as the dose of Dilaudid. So it's not about one opiate being stronger than the other, it's about the dose.
It's a dose thing, it's a potency, so they'll all do the same thing at equivalent doses. So we used to have that dose equivalency table, like it's this many morphine equivalents and so on and so forth. Now here's a question, Sherry Manor, wish my CRPS pain would taper only with nerve block. So chronic regional pain syndrome, and I'll tell you a little story real quick. When I did my song Blank Script, it was a parody about opioid addiction and the behavior that results in people who are addicted, some of which you mentioned, doctor shopping, calling in the middle of the night, self-dosing, losing the script, complaining of stuff. And one of the things I listed was, RST and abdominal pain, just as a throwaway thing, because you see it complained of in the ER by people who don't have it. Yes. I got vicious, angry emails from CRPS. Reflex sympathetic dystrophy and chronic regional pain syndrome are roughly the same thing, different names for the same thing. And this community was very hurt because it seemed like I was perpetuating the idea that their pain is not real, that it's in their head, or that they are drug seeking and not actually having pain. And I regretted that happened, and I realized, well, I know why I did it, but that doesn't make it undo the harm. So I added an addendum to the video where I explained that piece, and actually so I want to talk, for the sake of those guys, I want to talk a little bit about CRPS and what that is and why it's so horrible and how do you go about treating it.
So complex regional pain syndrome, it can happen after a nerve injury, and the symptoms are usually objective, which helps us in pain management. One thing in pain management is that a lot of things are subjective. So patients come in, I have pain, I have a headache, or I have,
pain, that's why it's our only subjective vital sign if pain is the 5th vital sign, right?
Yes.
Which, by the way, what do you think of that?
The 5th vital sign? Oh, disaster.
Disaster, right?
Disaster.
From an expert, it's a disaster.
Yeah, disaster.
So CRPS?
So you can have a nerve injury, or it can start on its own, but generally it's from a nerve injury. And what happens to the area is you get this sympathetic overflow. So let's pretend it's just the arm. If you have a wrist sprain, for example, and you don't heal, maybe the injury heals, but you still have pain. And then it changes, and the arm gets swollen, it gets red, it gets hot, or it gets cold and blue, and you have various different types of skin changes, vasomotor changes.
Physical changes.
Physical changes, and it's so painful you can't even touch the area. And I don't know how common it is. I didn't look up any of those numbers
Amanda
before.
Nuke says, I'm a 35-year-old hospice nurse diagnosed a year ago with RSD CRPS. I had no idea what chronic pain was like until I lived it.
Yeah, so CRPS is a truly horrible, painful condition.
Yeah,
Yes.
Yeah. So how do you go about managing it just in a broad, quick sort of way?
So
we
I
can't do it justice in this show.
Neuropathic agents are key. Yes, we use opiates in this condition, but I like the gabapentin, Lyrica type medications. Physical therapy is actually the mainstay of treatment for complex regional pain syndrome because people don't use the limb, they don't want to use it.
And that makes it worse.
And that makes it worse. We have to try to, it's very sensitized, so we have, what we order is desensitization physical therapy to try to desensitize that hand. There are nerve blocks that people can get. Spinal cord stimulation has been shown to be very helpful for complex regional pain syndrome patients. So there are a few things you can do that we have in medicine that do help complex regional pain syndrome, but it is very painful.
And when they go to the ER, sometimes when they failed and they need breakthrough opioids, they get judged very harshly as dependent drug seekers,
yes,
etc.
That's one of the, unfortunately.
Hey, so Z, we got about 10 minutes left. You want to do overtime comments?
Let's hit overtime comments.
What's that?
All right, so I got one from Danny Clark. Dr. Kathy, how often do you find yourself firing patients from your practice?
Okay, so I never fire. I've only fired maybe 2 or 3 patients from my practice, and it's not because we had an opiate problem. So opiate abuse, misuse, addiction, they're problems, but I'm not going to fire a patient for that. What I do is I say, you know what, we're going to do non-opiate pain management. And we have so many things that we can do that are not opiates. I think one of the problems, patients think that pain management is opiates. And they're told that. They're told that by even their primary care physicians. You know what, I've been giving you Percocet, but I don't want to prescribe this anymore. Go to pain management and get it from them. And so then patients' perception of pain management is that pain management is opiates. And it's very common even today that I will go through a whole visit, and at the end, I'll say, okay, we're going to do therapy, we're going to do an anti-inflammatory, we're going to do some gabapentin, we're going to injections, or here's some exercise prescription, whatever. And then at the end of the visit, they'll say, okay, that's great. Now, what are you going to give me for my pain? And so then you have to expectations. You have to then you have to take a step back and say, okay, this patient or this person doesn't understand pain management.
Right.
And so then I say, look, opiates are one thing in the big toolbox that I have. And it's just one thing.
Yeah.
And so I say, look, Tylenol is pain medicine. NSAIDs are pain medicines. Neuropathic agents like gabapentin is a pain medicine. Then you have your norepinephrine, serotonin type medications that are pain medicines. And tramadol is in a whole nother category of itself. So I go through and say opiates are just one medicine in the toolbox of medicines that I have.
You know what my dad would say? Johnny Walker Black is a pain medicine, okay? Because you are paining me with every one of your nonsense that you're telling me. I'm going to drink myself into a stupor, okay?
Carwile Leroy wants to know, what pain meetings does Kathy like/respect?
Pain meetings?
Particular pain conferences, things that you like.
Pain conferences. There's some good ones. So I do like, Harvard has a few conferences. Is this for primary cares?
I would assume.
The primary care conferences, Harvard has one in June that's fantastic. I went to it in my first practice before I had my pain fellowship. Cleveland Clinic has a good conference. There is something called Pain Week in September. It's actually in Las Vegas every year. It's very good.
Every week is Pain Week in Las Vegas.
Yeah, every week is Pain Week
here.
Yeah, but the conference is in September. And then off the top of my head, specifically for pain management, I would say off the top of my head, those 3 are good ones.
And here's a comment, Rebecca Bennett Souden. I'm an RN in recovery from opioid addiction, and funny how my pain went away after I got clean. I had a severe neck injury, and working through the pain was the best for me. No meds needed.
Thank you.
Isn't that amazing?
It's a wonderful thing.
Thank you for your bravery in
Yes.
coming forth and saying, I've struggled with this, because many of us in healthcare have a stigma around opioids, and there are a lot of healthcare providers who suffer. Do you see a lot of them in your practice, not violating HIPAA?
The physicians that
nurses
only
or
2
pharmacists.
actually. Yeah, nurse, yes. There was one physician that we had who was actually addicted to benzos at another practice somewhere in the middle of nowhere. But not opiates. Yeah. But they do get. Physicians are humans, and they are. They
Speak
are also
for yourself, woman.
Yeah.
I'm a robot, 90%.
He's superhuman over here.
Subhuman,
so he
actually.
doesn't get subhuman. He's not human. But we also can get addictions. So,
In fact, we have access. We have better access than most people. We're stressed.
Yep.
We are not good at expressing emotions.
Yep.
We're good at compartmentalizing.
Yep.
And all of the above. Other comments that you're seeing, Tom? I'm looking through them.
Let's see. I had one up here. It says, how can you sit there and say that one condition is more horrific and truly painful over another? That's from Jamie.
No, I was just saying that complex regional pain syndrome is very painful. I wasn't judging based on other pain conditions.
I'm going to judge because I'm going to say that pain is subjective. So
Yes.
it's all relative.
Right.
And Dr. T has to be very objective and is very professional. I don't have to be that. I'm going to say some people suffer a lot more because it's all here. And so they may magnify their suffering even if they have the same condition. So pain is a very subjective thing.
Yes.
Yeah.
Yep,
Kathy,
absolutely.
Tim Steck wants to know, how does confirmation bias play into your diagnosis?
So confirmation bias in
Of what?
in the
I
sense that
think Tim is trying to get at, are you prejudging patients? How do you size up a patient?
So in other words, you might say, I think this guy is addicted, therefore any evidence I see of addiction is going to confirm my bias, even if it's neutral evidence. Like the guy went to the store and actually lost his Dilaudid and we're judging him.
I really avoid judging people. I mean, I'm gathering information and I'm trying to make people better. So I don't think, oh, this person's an addict. And if I suspect an addiction, I'm going to address it right away. I'm not going to wait for it to get worse.
Yeah.
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 Everybody has been overwhelmingly positive on Kathy in the comments. Everybody loves you, Kathy.
Okay, good.
There are a few people, like Ronnie Ann, who
Ronnie Ann,
says,
I would not go to your guest doctor.
guest.
She has no compassion.
She had no compassion.
sorry.
Based on what? Because based on what exactly?
I don't know.
I don't know. But
don't
see, this is
know.
do you get this experience where you can do everything right in an interaction?
Yes.
But that person comes with a certain filter or a certain perception or a certain emotional substrate where nothing you say is going to be the right thing for them, and
Right.
they're going to say something like that.
Right.
Yeah.
No, absolutely. And I not, again, like I said before, is that you may be with a physician and not trust them or feel comfortable with them, and I recommend getting a new physician. And
Yeah.
also for physicians, you can't help every single patient.
Yeah.
And that's true on both sides.
I'd also like to say people in the comments have been saying they would fly out to see Dr. T.
Yeah, she's
So-
gonna have too much business now. You're gonna get every drug seeker in the country coming over here like, Dr. Kathy, I heard you really like Dalala. what did the guy call it?
Dilaudid.
Dilaudid.
And Lynette
God.
says, I think she's a great guest also.
She's amazing.
Let's see.
I like sitting here with her because she makes me feel like I'm a professional, even though I'm not. I have a lot of people who entered the hospital because they were not treated very nicely by staff and because they refused opioids and they were moaning, but they were afraid to, quote, get addicted. Elizabeth Cicantelli. So the underuse of opioids. Do you see
Right,
that?
and that's a problem too. So most people, if you look at the numbers, I think 100 million people in the United States have chronic pain or have some type of chronic pain. And the addiction numbers, we had last year, maybe 2015, 30,000 deaths from overdose. So addiction in general is not that common to opiates. But I educate the patients. Here are the risk factors to getting addicted. And so we go through what we know from studies, the family history, personal history, age, women who have a history of sexual abuse are at higher risk. And I go through all the risk factors with them and really educate the difference between tolerance and dependence to opiates, which is normal, and then addiction, which is an abnormal response, and it's not going to happen in every person.
Is there a phenomenon of people trying to numb emotional pain with opioids and that being a risk factor for dependence addiction?
Yes, I do think that, but it's so hard to know
To
who
tease
those
it out.
people are.
Yeah.
You really need to get family involved,
Right.
friends, people that are around the patient more that may suspect that. But even then, it's pretty hard.
Opinion on, Tracy Evan Coogan says, opinion on intrathecal pain pumps, please.
Oh, I think they can be good for some conditions. I don't do intrathecal pain pumps. They came about really for cancer pain, and they're really good for cancer pain. I have seen a few people do well with them, but I don't do them as much. Yeah.
My pain management doctor said to call the pain clinic before going to the ER for pain, Sherry Manor. Do you tell your patients to give you a call?
Yeah. I mean, chronic pain, when you have more pain, as long as you didn't have any new trauma, a car accident, a fall, it's not a true emergency. We would like people to really avoid the ERs because they have become really the front line of the opiate epidemic. So people were coming in just to get a high. And so there may be some undertreatment of pain in the ER now because of that, and it's understandable.
And we see it, I was just at the ASEP conference and talking about opioid overuse addiction, the crisis and all that was at the top of their mind, but the question is, are we now not managing these things very well?
Yes,
Or is
that
the
is a
pendulum
risk.
swinging the other way?
Yes.
I've seen a couple comments about Tom's mic not being on. Is Tom's mic on?
No, it's that my mic was on, and I was discussing the time left in the show with Logan.
That's pretty standard because you guys are total buttholes that way. How much time do we have left? Because we're at
We
we're
can
at
go.
an hour.
We can go another 10 or 15 minutes.
Probably 10, right? Because
Yep.
we're at an hour. Because we run out of recording space and then we can't repost the show. because
Susan
we're
Robinson
ghetto.
says Kathy has a wonderful, professional, scientific manner. That's what I think.
Oh, thank you.
You're fired.
Also, Dr. T, may I have some drugs?
Starts with a D.
No.
Can I get some
Please.
Dilaudid?
You could go to the gas station and get that other stuff you're talking about.
I'm gonna get some kratom. Get high.
I'm gonna get some kratom, get high AF, and then some Dilaudid. And the only thing that helps me starts with a Z, and that's Z-Dog Snitches, because this show is off the chain. By the way, if y'all like this show, please share it. Please share the podcast too. And if you guys like Kathy, let me know, because I like Kathy. I think she's a great co-host. I'm excited to have her on for topics that even don't have anything to do with pain, because it's nice to have another doctor to bounce ideas off, especially someone who's smarter than me. And what else do we got here, Tom? Any other great comments that you see? There's so many, and if you see something, feel free to shout it out.
Let's see.
It's kind of hard to read them real fast. Objective assessment can be very frustrating to some pain patients and can come off as not having compassion or not caring, but it's truly essential to seeing the whole picture. Laura Tobias. So what is objective assessment? Are you looking at tachycardia, physical signs, other
So
things?
in acute pain, you'll see high blood pressure, increased heart rate. But in chronic pain, you don't see those changes. So it depends on what the condition is, what they've been diagnosed with, what I'm looking for. So complex regional pain syndrome, the allodynia, hypersensitivity, the swelling, the color changes. But in some other pain conditions, we don't really see it, and so pain truly is subjective, and everybody has a different experience of pain, and they feel pain differently. So their genetics, their environment, their psychosocial environment really go into how they experience their pain.
So Z, here's one from a while back from Zelda Master. Says, my 17-year-old daughter had oral surgery and was given 30 tablets of painkillers. I gave her 0 and managed her pain with Motrin. I see what you did, Zelda. You kept those pills for yourself, girl. Way to do it.
The legend of Zelda.
The
She's killing
exact
it.
problem that I discovered when I went in for a minor hand surgery. Yeah, but there's
And
a
do you
lot.
think this is contributing to the opioid epidemic for the youth right now?
It's unneeded opioids.
Um,
Excessive opioids.
Yeah, well, I guess it depends on what they do with those extra tablets.
What do they do with those extra
Yeah, what
tablets,
are they
Tom
doing with
Heineberg? Because
them?
We
Tom knows.
sell them for cash money, or we take them to get high AF. It's great.
So he's not even kidding. So Tom went to school in Las Vegas, and a lot of his classmates were abusing their parents' opioids.
Yep.
They were getting it out of the cabinet, diverting it to themselves, and mixing it with benzos, other drugs, and getting high. And this is a path to, as Yoda would say, this to the dark side. This leads.
we just call it getting turnt, Z.
Can I get your ship out? Getting turnt? Is that what you said?
Getting turnt?
Getting turnt? Like turntable?
Yes, exactly.
Oh my. Guys, I think we have run the course of this show into the ground, and it's been such a pleasure to have Dr. Kathy Travnicek on the hit us with Logan, hit us with her little descriptor there.
One more,
so
one
people
more?
can see one more. There it is.
And
Travnicek.
then
Skiing is for losers. Why do you say that?
Because I'm a snowboarder, it's the best.
Hell yeah.
heck yeah, that's how my L5S1 got out, y'all. What's up, snowboarding?
Ain't no party like an opioid party, because an opioid party don't stop. Yo. On that note, guys, you can click the link in this description, and I'll put it up on the website and on the podcast to go get continuing medical education credit for the wonderful teaching that Dr. Kathy did for us. Well, let's give her a round of applause. Oh my gosh. What
You guys
a
thank
joy.
Dr. Kathy for getting you CME, y'all.
And we got suits. It's Sunday. It's against medical advice. This is the only show for frontline healthcare providers by frontline healthcare providers that is trying to build Health 3.0 with amazing guests, moderately developmentally delayed co-hosts, which would be Tom Heinever. Hey, no, not Logan.
I'm amazing.
Logan is amazing.
This suit smells like a man died in it. And
And we out.